Welcome to the Deep Dive. This is the show where we take critical, complex knowledge, the kind that truly separates the novice from the expert, and distill it into clinically relevant, high-fidelity insight designed specifically for you, the advanced learner.
Exactly.
Today we are undertaking a deep dive into a single molecule that really defines emergency airway management and clinical risk. Succinylcholine?
Succinylcholine, yeah.
Yeah.
Or Suthase, as we all call it.
Right, Sissy. Our mission is to move beyond just rote memorization and explore the nuanced pharmacology, the catastrophic risks, and the profound clinical judgment required to handle this essential drug safely.
And this is, I'd say, perhaps the most important foundational topic for any MD anesthesiology candidate. SE is a historical and, a current cornerstone of critical care in anesthesia.
Absolutely.
You have to understand it inside and out, not just to score well in your exam, but because the knowledge wrapped up in this one drug, its mechanism, its metabolism, its dangerous contraindications, it's tested so rigorously because it represents critical patient safety knowledge. And while we have alternatives today, SE is still the prototype for rapid onset. Mastering this is just non-negotiable.
Okay, let's unpack this essential agent then, starting right at the foundation that examiners are looking for. Definition and classification. What is succinylcholine formally?
Well, succinylcholine, or S, is unique. It's the only depolarizing neuromuscular blocking agent, or NMBA, that we currently use in routine clinical practice.
The only one?
The only one. Everything else we use, rocuronium, vicuronium, they all fall into the non-depolarizing category. Chemically, we classify it as a quaternary ammonium compound.
And that chemical feature, the quaternary ammonium part, that's really important, isn't it?
It's absolutely crucial. That fixed positive charge dictates two things. First, it makes it attracted to the negatively charged nicotinic receptors on the motor end plate. And second, it means it can't cross lipid barriers.
Like the blood-brain barrier.
Exactly. Or the placenta. It keeps it where we want it.
So that structure leads us to the core concept here. Why do we call it a depolarizing agent? What makes its action so fundamentally different from, say, rocuronium?
It's all about what it does first. Most other NMBAs are antagonists. They just sit on the receptor and block it.
They're just blockers.
Right. But SE is a direct agonist. It binds to the postsynaptic nicotinic acetylcholine receptors, and it actually stimulates them, just like ACE would.
So it mimics ACE.
Perfectly. It opens the ion channel, causes depolarization of the muscle membrane, and that's what you see clinically as those muscle twitches, the fasciculations.
Okay, so if it mimics ACE and causes depolarization, why doesn't the block wear off immediately, like with normal neurotransmission?
And that's the million-dollar question. That's the key. SE is not rapidly broken down by acetylcholinesterase, the enzyme that's right there at the neuromuscular junction.
It's resistant to it.
It's resistant, so it just persists there for minutes, repeatedly stimulating the receptors, holding those channels open. The muscle membrane can't repolarize. It can't reset itself.
It's stuck in a depolarized state.
Exactly. And this prevents the voltage-gated sodium channels right next to the junction from recovering. So no new action potential can be transmitted. That leads very quickly to flaccid paralysis. That sustained depolarization is why it's a depolarizing block.
Which functionally is why SE has this legendary and sometimes, terrifying status, even with safer alternatives now. What is its core importance in today's practice?
It really comes down to its unparalleled kinetics. I mean, you have this unique combination of an ultra-rapid onset.
How rapid are we talking?
30 to 60 seconds after an IV dose. And an ultra-short duration, usually 5 to 10 minutes. That combination makes it the undisputed champion for emergency airway management.
So it's the classic RSI drug.
It is the original and still the prototypic drug for rapid sequence induction, or RSI. That speed buys you critical time to secure the airway in a patient who's at high risk of aspiration. You're minimizing that window of danger.
So if you're an MD candidate preparing for that long answer exam, the classic 20-mark question on SU, what's the expected scope? What are the absolute must-haves for a top score?
Right. The examiners want a comprehensive, structured answer that links the basic science to clinical risk. So core components would be, first, a detailed breakdown of the mechanism of action.
Not just saying it's a depolarizing agent.
No, you have to meticulously distinguish between phase I and phase II block. You need to include the nerve stimulator findings for each and what that means for management. Second, the entire pharmacokinetics section, focusing heavily on metabolism by pseudocholinesterase.
And the dibutane number.
And the dibutane number, absolutely. And finally, you must give a clear, justified list of the life-threatening contraindications, especially the hyperkalemia risk. And then you have to cap it off with a critical comparison to rocuronium and sugammadex for RSI. If you miss any of those, it's an incomplete answer.
Let's transition from the clinical side into the chemistry that allows for all this. For the student facing Aviva, being able to visualize the molecule and its link to ACA is critical. What defines the chemical structure of ACA?
Okay, so chemically, it's a dicholine ester of succinic acid. But here's the detail that makes it easy to remember. SEK is essentially a symmetrical molecule. It's made of two acetylcholine molecules that have been joined together.
Two SE molecules back to back.
Exactly. They're linked through an ester linkage, joining their acetate methyl groups. And this doubling, this dimer structure, is why it can bind to the nicotinic receptor so well and act as an agonist. It just fits perfectly.
So it's basically a superagonist because it's a dimer of SE. And that quaternary ammonium ion feature, the positive charge, that's what keeps it in the bloodstream, right?
Precisely. All NMDAs have this feature. They're all quaternary ammonium compounds. This gives them that fixed positive charge at body pH. And since charged molecules don't cross fatty cell membranes well,
They're not lipid soluble.
right, they can't easily cross the blood-brain barrier. And that's vital. It explains why SE works exclusively at the neuromuscular junction and why it doesn't cause, central side effects.
Let's move to the practical stuff. Formulation, storage, handling, basic safety points, but easy marks in an exam. How do we find SC in the operating theater?
It's usually presented as a colorless solution of the chloride salt. Most commonly, it's a concentration of 50 milligrams per mil in a 2 milliliter pool.
Okay.
The critical storage requirement, and this is key, is that it must be kept refrigerated at 4 degrees Celsius. It's not very heat stable. Warmer temperatures speed up its degradation and it loses potency. That's why it's always in the drug fridge in the OT.
And what's the crucial compatibility point, the one that can lead to a complete disaster if you overlook it?
This is a huge safety checkpoint. SC solutions are chemically unstable and they're rapidly destroyed by an alkaline pH. So it must never be mixed in the same syringe or given through the same IV line without a good flush if that line has had a highly alkaline drug in it.
The classic example being thiopentone.
Thiopentone is the textbook example. It's highly alkaline. If you mix S with thiopentone, you've essentially just neutralized the ester. You get a failed block, which during an RSI is, well, it's catastrophic.
Let's dedicate the time now to the mechanism of action. This is the highest yield topic because everything else, the effects, the complications, stems from this. We start at the motor end plate. What are the specific receptors?
And as an IC analog, ESH targets the nicotinic AT receptor. In adults, that's primarily the alpha-2 beta-delta epsilon subunit configuration.
Right.
When ESH binds, it acts as an agonist, opens the ion channel, lets sodium ions rush in, and that causes the end plate depolarization. But like we said, the problem is it just stays there. It's resistant to the acetylcholinesterase at the junction.
So that persistence keeps the motor end plate depolarized and refractory to any new signals.
Exactly.
And this mechanism is divided into phase 1 and phase 2. Let's detail the features of a phase I block, the depolarizing block. This is the effect we're actually trying to achieve clinically.
Phase I is the standard effect you see after a single intubating dose, say 1 to 1.5 milligrams per kilogram. The primary mechanism is that persistent depolarization, which immediately leads to the inactivation of the surrounding voltage-gated sodium channels.
And those channels are what propagate the signal down the muscle.
Correct. So if they're inactivated, you get functional paralysis.
How does this phase I block look clinically?
Clinically, the initial binding causes that transient universal muscle twitching the fasciculations. That's immediately followed by a profound flaccid paralysis.
So twitching, then silent.
Exactly. And on the nerve stimulator, this is critical for your exam. If you deliver a train of 4, a TOF stimulation, you'll see an equal depression of all 4 twitches. The TOF ratio is 1.0. There is no fade.
No fade at all.
No fade. The muscle membrane is uniformly refractory.
Okay, and here's the classic exam trap, the major clinical hazard. The response of a phase I block to anticholinesterase agents like neostigmine. Why is this absolutely contraindicated?
Right. In a phase I block, giving an anticholinesterase like neostigmine will potentiate and deepen the block. It makes it worse.
It makes it worse. Why?
Because these agents are designed to inhibit cholinesterases. And they don't just work at the junction. They inhibit the plasmacholinesterase, Bushi-E, which is
Right.
what's responsible for breaking down estrus in the blood.
So you're blocking the clearance mechanism.
You're blocking the clearance mechanism. You slow down the breakdown of estrus, you get higher concentrations lingering at the junction, and you intensify and prolong that phase I block. You can dangerously extend the apnea. This is a point you have to nail in the exam.
Okay, now let's talk about the transition to a phase 2 block. The desensitizing or dual block. What triggers this shift?
Phase 2 block is an abnormal transition. It's not what we want to see. It happens after prolonged or high cumulative doses. We're talking more than 7 to 10 milligrams per kilogram total dose, or after a sustained infusion.
Or in certain patients, right?
Or it can happen rapidly and unpredictably in patients with a genetic atypical pseudocholinesterase enzyme. The mechanism shifts from just persistent depolarization to receptor desensitization.
So the receptor changes.
The receptor changes its shape. The SH agonist binds, but the ion channel fails to open reliably. On top of that, high SO concentrations start messing with prejunctional receptors, which are involved in atriomobilization.
And how does phase 2 look clinically? What makes it so confusing compared to phase 1?
Clinically, a phase 2 block looks almost exactly like a standard non-depolarizing block. The muscle membrane has nearly repolarized, but the receptor is just unresponsive, desensitized.
And recovery is much slower.
Significantly slower than the usual 5 to 10 minutes. It could last for hours in a patient with a genetic deficiency. And here's the crucial difference from phase 1. A phase 2 block can be partially or sometimes even fully reversed by anticholinesterase agents.
Because it's acting like a competitive block now.
Precisely. It's mimicking the NDMRs.
This brings us back to the nerve stimulator. The visual evidence from the monitor is key to figuring this out. How do the phase I and phase 2 findings differ?
The difference is striking. You have to memorize this. For a phase I block, you have equal depression of all 4 twitches in the TOF. TOF ratio is 1.0, no fade, and also no post-tetanic facilitation or PTF.
The system is just saturated.
Completely. Now for phase 2 block, it exhibits clear fade when you do a TOF or tetanic stimulation. The twitches get progressively weaker.
Fade is the hallmark.
Fade is the hallmark. And you'll see post-tetanic facilitation. A strong tetanus, a short pause, and then the next single twitch is temporarily stronger. This pattern fade in PTF makes the phase 2 block electrophysiologically indistinguishable from a standard non-depolarizing block. That's the monitor finding that tells you, 1, the block is prolonged, and 2, you might be able to enter reversal, though ventilation is always the primary management.
Let's move on to pharmacokinetics. The kinetics of SEH are, well, they're extraordinary, and they're entirely dependent on that metabolism pathway. Let's start with its speed. Why is it the fastest NMDA available? A full block in around 60 seconds.
Its speed comes from a few things. First, it's a small molecule, it's flexible, and it diffuses extremely rapidly through the extracellular fluid to get to the motor end plate. Second, we give a relatively huge dose.
We overdose them, essentially.
We do. 1.0 or 1.5 milligram per kilogram for RSI is well above its ED95. This ensures immediate and complete receptor saturation. That combination of rapid distribution and high dose gives you a maximal effect almost instantly.
And the ultra-short duration, 5 to 10 minutes, what's the singular thing that determines this brief action?
It's entirely dependent on plasma pseudocholinesterase, also called butyrylcholinesterase or butyropecia. This enzyme is made by the liver, it circulates everywhere in the plasma, and it's the termination switch.
So here's another classic Viva question. The block ends not because of metabolism at the junction?
Correct. It ends because S diffuses away from the junction and into the bloodstream, where Bushi is waiting to gobble it up and hydrolyze it. That distinction is critical.
So Bushi is basically this massive garbage collector for shish. How effective is it, and what are the breakdown products?
It is stunningly efficient. Studies show that only a tiny fraction, maybe 10 to 20% of the IV dose, actually survives that first pass through the plasma to even reach the NMJ.
Wow.
Bushi rapidly hydrolyzes ESH into succinylcholine and choline, and you have to mention succinylmonocholine because it's not totally inactive.
It's a weak muscle relaxant itself.
It is, and it's metabolized much more slowly to succinic acid and choline. So this weakly active metabolite can, contribute a little bit to prolonged effects, especially after big doses.
Given this rapid metabolism, what is the drug's half-life, and how much is just excreted unchanged?
The elimination half-life in the plasma is incredibly short. We're talking somewhere between 16 and 47 seconds. This rapid clearance is why recovery is so quick. And because it's so efficiently metabolized in the plasma, a minimal amount, only 2 to 10%, is excreted unchanged by the kidneys. This is why we often consider standard doses safe in renal failure as long as their potassium is normal. Clearance isn't really dependent on the kidneys.
Let's talk pharmacodynamics. Beyond the paralysis we want, SCH is famous for its widespread and sometimes dangerous side effects. This is because it's just not very specific, is it?
Not at all. Let's start with the skeletal muscle effects. We covered the fasciculations followed by paralysis, but there's a difference in onset speed. Paralysis is fastest in the central muscles, the vocal cords, the diaphragm, which is perfect for intubation.
And slower in the periphery.
Slower in the periphery, like the adductor pollicis muscle in the thumb, which is where we monitor recovery. This difference explains why it's great for intubation, but often leads to muscle soreness afterwards.
Let's move to the notoriously complex cardiovascular effects. Why can SI cause bradycardia in one patient and tachycardia in another? It seems so unpredictable.
The complexity comes from the fact that SE stimulates all cholinergic receptors, nicotinic ones in the autonomic ganglia and muscarinic ones in the heart. The net effect is a bit of a mixed bag.
So it depends on the dose.
It's often dose-dependent. Bradycardia and dysrhythmias are more common with low doses or after a second dose, and especially in children. This is a vaguely mediated effect from stimulating muscarinic receptors on the SA node. It can cause sinus bradycardia, junctional rhythms, even asystole.
But high doses can do the opposite.
Right. High doses can cause tachycardia and hypertension. This is from stimulating the sympathetic ganglia, the nicotinic receptors, which can lead to a release of catecholamines. The takeaway is that it's a tug-of-war between the parasympathetic and sympathetic systems. That's why pre-medicating with atropine is so important in high-risk groups like children.
The respiratory effects are pretty direct.
They are definitive. ESH causes complete paralysis of all respiratory muscles, including the diaphragm. This means mandatory mechanical ventilation is required from the second it's given until it wears off.
Now for the pressure effects. These are critical safety checks. Let's tackle intraocular pressure, IOP. Why does SC raise it?
SC causes a significant but transient increase in IOP, maybe by 5 to 10 millimeters of mercury. It's likely due to the tonic contraction of the extraocular muscles, which are also skeletal muscles, and they depolarize. This means you need to be cautious in patients with penetrating eye injuries, where you might risk vitreous extrusion, or in patients with severe glaucoma.
Next, intracranial pressure, ICP. This is a big debate in neuroanesthesia. What's the precise mechanism for the rise?
The ICP rise is modest and it's transient, usually around 5 millimeters of mercury, and mostly seen in patients who are lightly anesthetized. But crucially, the rise is indirect.
It's not a direct effect on the brain.
No. The mechanism is fascinating. The generalized muscle fasciculations stimulate peripheral muscle stretch receptors. This sends a huge barrage of sensory information up to the brain, which causes a reflex increase in cerebral activation and blood flow. And since the skull is a closed box, more blood flow means more pressure.
So if the mechanism is tied to the fasciculations, how can we block that rise? And is SC ever truly a no-go in a high ICP patient?
We can blunt the rise in a couple of ways. Deep anesthesia helps. Or we can use pretreatment, a defasciculating dose of a non-depolarizing agent a few minutes before the SA, or giving intravenous lidocaine. These reduce the fasciculation, so they remove the trigger.
Okay.
But the critical point for your exam is that SAs is generally not an absolute contraindication in high ICP. The risk of hypoxia and hypercarbia from a delayed intubation causes a much bigger, more sustained, and more dangerous rise in ICP than the transient effect of SCP. Airway control is always the priority in neurotrauma.
And finally, the effect on intragastric pressure, IGP, which ties back into our main concern with RSI.
Right. Similar to the other pressures, SAs increases IGP because of the initial squeeze from all the fasciculations. This might overcome the tone of the lower esophageal sphincter, theoretically raising the risk of regurgitation. While it's hard to pin aspiration events solely on SA, the rise in IGP is a definite risk factor in a non-fasted patient.
Let's detail the applications now. If an examiner asks for the clinical uses of SC, what is the single primary indication that justifies its continued use, despite all these risks?
The primary defining indication, without a doubt, is rapid sequence induction, RSI. This is mandatory for patients with a full stomach, severe GERD, bowel obstruction, anyone at high risk for aspiration. The whole idea is to minimize the time between loss of consciousness and securing the airway with a cuffed ETT.
And the standard RSI technique uses EST.
The standard RSI technique uses SC at 1.5 milligrams per kilogram right after a rapid injection of the induction agent.
Beyond the standard RSI, what's the second critical scenario where SEA's unique kinetics give it a safety advantage?
Emergency airway management in a potentially difficult airway. When you need rapid, profound relaxation to secure a difficult airway like in trauma or airway obstruction, SE is indicated. The ultra-short duration is the key.
It's a built-in safety net.
It's a built-in safety net. In a cannot intubate, cannot ventilate scenario, if you fail, the drug wears off in 5 to 10 minutes and the patient can start breathing again spontaneously. That temporal advantage is why SEA is often chosen even over rocuronium with Sugammadex if there's a known difficult airway and maybe some uncertainty about immediate Sugammadex availability.
What about non-intubation uses? Are there short procedures where it's beneficial?
Yes, it's still frequently used for muscular relaxation during electroconvulsive therapy, or ECT. The goal there isn't intubation, but preventing musculoskeletal injury during the seizure. The rapid onset is perfect so the patient can wake up and breathe very shortly after.
Let's delve into dosage. This requires careful attention to context-standard intubation, RSI, special populations. What's the standard IV dose, and how does the RSI dose differ?
The standard intubating dose for a healthy adult is 1 milligram per kilogram IV. For RSI, however, we usually bump that up to 1.5 milligrams per kilogram.
Why the higher dose?
It's strategic. The ED95 is around 0.5 to 0.6 milligrams per kilogram, so 1.5 is a significant pharmacological overdose. The reason is simple. You want to guarantee immediate, complete receptor saturation to get the fastest possible onset and the most profound relaxation needed under pressure.
And what about when you can't get IV access in an emergency? When is the IM route indicated?
The IM route is strictly for dire emergencies when IV access has failed. Often in small children or uncooperative patients, the dose is much higher, 4 to 6 milligrams per kilogram IM.
That's a huge dose.
It is. And the onset is slower, which is a problem. But crucially, if you give it IM, especially in children, you must give atropine concurrently, usually 0.02 milligrams per kilogram.
Why is that mandatory?
Because that high dose and slower absorption dramatically increase the risk of profound, vaguely mediated bradycardia, which can easily lead to cardiac arrest in a child.
Speaking of pediatrics, why do infants and children need a much higher dose per kilogram than adults for IV administration?
This is a classic question. It's about pharmacokinetics. Infants and children have a larger volume of distribution relative to their body weight. The drug gets diluted into a larger extracellular fluid compartment. So an infant might need 3 milligrams per kilogram and a child 2 milligrams to get the same plasma concentration as 1 milligram per kilogram in an adult.
So let's consolidate the kinetic differences by route.
BioV gives you that critical 30 to 60 second onset. IM is much slower, variable, often taking several minutes, which really compromises the whole point of RSI. The short duration, though, remains about the same, 5 to 10 minutes, because the clearance mechanism, Bushi in the plasma, is the same.
Given the laundry list of severe complications we're about to get into, it's important to reinforce why SKI is still used. If you're asked to list its advantages, what are the 3 definitive points?
The advantages are few, but they are unmatched. First, unmatched rapid onset. It is the fastest NMB there is, complete block in 60 seconds.
Nothing else can reliably match that.
Nothing. Second, ultra-short duration. That 5 to 10 minute window is the shortest available. And like we said, that's a direct safety feature. If you fail to intubate and can't ventilate, spontaneous recovery is just minutes away. High-dose rocuronium doesn't have that unless Sugammadex is right there in your hand.
And the third point?
Excellent intubating conditions. SEJ produces a profound, reliable, and instantaneous relaxation. The feel of the jaw and vocal cords is often considered superior to non-depolarizing agents, ensuring the best possible shot at a first-pass success.
Okay, now we enter the critical core of SG pharmacology, the complications. This is heavily tested because these are potentially lethal and preventable. Let's start with the least dangerous but most common, fasciculations and myalgia.
Right. Fasciculations are an unavoidable consequence of the phase I depolarization. They're universal. Postoperative myalgia, or muscle pain, is a very common, though minor, complication. It happens in up to 50% of patients, especially young, mobile adults. It's thought to be from that asynchronous, forceful muscle contraction during the fasciculation phase.
Now for the high-stakes risk, the one that causes cardiac arrest, hyperkalemia. Can you explain the physiological mechanism, starting with the normal, benign potassium rise?
The mechanism is straightforward but profound. The massive, generalized muscle depolarization causes a net efflux of potassium, K+, from inside the muscle cells out into the plasma. In a normal, healthy patient, This causes a modest, transient, and clinically benign rise in serum potassium of about 0.5 to 1.0 millieq per liter.
Which is usually fine.
Usually well tolerated by a healthy heart. It only lasts about 10 to 15 minutes.
So when does this normal rise become catastrophic? What's the core mechanism in these high-risk patients?
This is what you absolutely must understand for your exams. Catastrophic hyperkalemia happens in conditions where there's an upregulation and spread of extra-junctional fetal-type A sheep receptors.
So different receptors start popping up all over the muscle.
All over the muscle cell membrane, not just at the junction. This proliferation happens in response to chemical denervation or severe injury. When SGs comes along and stimulates these new, widespread receptors, the ion channel opening is massive and sustained. This results in an uncontrolled, huge efflux of potassium.
How high can it go?
It can raise serum potassium by 5 to 10 ME per liter or even more, leading directly to cardiac arrest.
And the specific high-risk patient groups that have this receptor upregulation, this is the core of the contraindications list.
Yes. The high-risk groups are all about widespread tissue damage or denervation. First, extensive burns. The risk starts to increase sharply from day 3 post-injury and can last for 6 months or more. The first 24-48 hours are generally considered safe, but after that, it's absolutely contraindicated.
Okay, what else?
Spinal cord injury, stroke, any upper motor neuron lesion. Denervation causes receptor proliferation, also severe trauma, crush injury, rhabdomyolysis. And fourth, acute or chronic neuromuscular diseases. This is crucial, especially Duchenne's muscular dystrophy in children. ISH can cause rhabdo and severe hyperkalemia in them.
And even just being immobilized for a long time.
Yes. Prolonged immobilization or sepsis can also lead to enough upregulation to pose a serious risk.
Let's briefly revisit the CVS risks, specifically bradycardia.
The vaguely mediated bradycardia is a major risk, especially in infants and children. As we said, even a standard IV dose, or definitely a second dose, can cause profound bradycardia or systole. Atropine pretreatment is mandatory in this population.
We've covered the pressure increases, but let's remind the listener of the two final, truly catastrophic complications, MH and masseter spasm.
Right. Malignant hyperthermia, MH, is a genetic disorder of skeletal muscle. SG is one of the two major triggers, along with volatile anesthetic agents. It must be rigorously avoided in anyone with a personal or family history of MH.
And masseter spasm is related.
Closely related. Masseter muscle spasm, or trismus, is an intense jaw muscle rigidity after SC that can make intubation impossible. Crucially, it's considered a major warning sign of underlying MH susceptibility, and it means you need to stop all triggering agents and start the MH protocol immediately.
And finally, the metabolic complication, prolonged apnea.
This results from the inability to metabolize the drug because of pseudocholinesterase deficiency, which can be genetic or acquired. Without that rapid breakdown, the block can be extended for hours, requiring prolonged mechanical ventilation.
Okay, the ability to separate absolute from relative contraindications is a hallmark of safe practice and is heavily tested. Let's formally lay out the conditions where SE is absolutely forbidden.
Absolute contraindications are where giving SE carries an unacceptably high risk of a lethal complication. So number 1, major burns, specifically after 48 hours.
2, severe trauma, crush injury, massive denervation.
3, upper motor neuron lesions like a spinal cord injury or lower motor neuron disease like Duchenne's. 4, pre-existing hyperkalemia, say a K+ over 5.5, or severe acidosis.
And the last one?
Personal or family history of malignant hyperthermia. If the patient fits any of these, SCs is off the table. You have to use an alternative RSI plan, like high-dose rocuronium.
What about the relative contraindications? Situations requiring caution, where the benefit might occasionally outweigh the risk.
Relative contraindications demand careful judgment. First, pseudocholinesterase deficiency. The block will be prolonged, but you can ventilate the patient through it. It's an inconvenience, not usually an immediate life threat like hyperkalemia.
Penetrating eye injury.
Yes, due to the transient rise in IOP. And known increased ICP, which we've discussed. The need for a rapid airway often overrides this. And finally, renal failure.
Why is renal failure only relative?
Because SCs itself is safe in ESRD patients only if their baseline potassium is normal. If they're already hyperkalemic, that small transient rise from SCE could be disastrous. So you must know the potassium level.
Let's focus entirely on pseudocholinesterase deficiency. This demands a detailed understanding. We know Bushi controls the block duration. How does the level of enzyme activity correlate with the clinical duration?
This is a subtle point. The duration of action is only significantly prolonged when Bushi activity drops below 50% of normal.
So a modest drop isn't a big deal.
Right. The liver makes a huge excess of the enzyme, so if you're at, say, 75% of normal activity, you might only see the block extend from 10 minutes to maybe 15. It takes a severe drop, or the atypical enzyme, to cause a real problem.
Let's categorize the causes of this deficiency into genetic and acquired.
Okay, genetic deficiency is the most clinically important one. This involves an atypical Bushi enzyme, where a mutation reduces its ability to break down Bushi. If you're homozygous for the atypical gene, you have a grossly impaired enzyme, and the block can last anywhere from 1 to 6 hours or even longer.
And the acquired causes.
Acquired deficiency is when something depresses the synthesis or activity of the normal enzyme. Key examples are severe liver disease, like cirrhosis, since the liver makes Bushi, late pregnancy due to hemodilution, severe malnutrition, and certain drugs that inhibit Bushi, like neostigmine, some chemo agents, and metoclopramide.
To differentiate these, we rely on the Dibukane number. What exactly is that, and how do we interpret it?
The Dibukane number is a brilliant test. It's the percentage inhibition of Bushi activity caused by the local anesthetic Dibukane in the lab. Dibukane preferentially inhibits the normal enzyme, but is less effective against the atypical enzyme. So it's a measure of the enzyme's quality, not just its quantity.
So how does the number tell you what's going on?
A normal working enzyme is highly inhibited by Dibukane, giving you a high Dibukane number around 80. In contrast, the mutated enzyme in genetically deficient patients is poorly inhibited, giving you a low Dibukane number, maybe 20 to 30. This helps us phenotype the patient after a prolonged block and predict their future risk.
If we encounter a patient with a confirmed prolonged block from Bushi deficiency, what is the immediate, non-negotiable management?
The primary management is simple. Ventilation is the mainstay. The patient must be mechanically ventilated, kept sedated, usually in the ICU, until the drug is slowly broken down by other means and neuromuscular function returns.
What about reversal agents?
The critical point for the exam is that even though the block might look like phase 2, reversal with anticholinesterases is generally not recommended. You risk inhibiting any residual Bushi activity, potentially making it worse. The safest course is just to support the patient until metabolic recovery occurs.
Okay, let's move to comparison with non-depolarizing muscle relaxants. The main competitor for SG and RSI is rocuronium, especially now with Sugammadex. This comparison is the single most common clinical and exam scenario.
It is. The debate is a classic trade-off. Speed and duration versus reversibility and safety profile.
Let's break it down. Onset speed.
SD is the benchmark at 60 seconds. High-dose rocuronium, 1 to 1.2 milligrams per kilodrine, gets close, maybe 60 to 90 seconds. SD is still marginally faster, and some would argue more reliable in creating those perfect conditions.
And duration?
SD is ultra-short, 5 to 10 minutes. High-dose rocuronium is intermediate to long-acting, lasting 45 to 90 minutes. That long duration was always ROC's biggest drawback for RSI.
But the dynamic shifts completely when you factor in Sugammadex. How does that change the safety calculus?
Sugammadex changes everything. SD has no rapid reversal agent. You have to wait. Rocuronium, on the other hand, can be reversed rapidly and completely by Sugammadex in 2 to 3 minutes, even from a profound block.
That's a huge safety advantage.
It's transformative. If there's a risk of a difficult airway, or if SD is absolutely contraindicated, rocuronium at 1.2 milligrams per kilogram with immediate Sugammadex availability is now often the standard of care for RSI. The long duration becomes acceptable because it's immediately reversible.
How does vecuronium fit into this discussion, especially for renal patients?
Vecuronium needs a really big dose, around 0.3 milligrams per kilogram, to even try to match RSI speed, and it's still usually slower. The key issue with vecuronium is that about 30% is excreted unchanged by the kidneys. This means its action is significantly prolonged in patients with end-stage renal disease. ESH, on the other hand, is cleared by plasma Bushi, making it favorable in ESRD patients as long as their potassium is normal.
So, for the MD candidate writing that comparison essay, what's the crucial takeaway? How should they justify choosing one over the other?
The justification has to be individualized and risk-based. You emphasize that SU offers kinetic superiority, fastest onset, shortest spontaneous recovery. Rocuronium offers safety superiority through rapid chemical reversal.
So you knew an algorithm in your head.
Exactly. Examiners want to see that thought process.
Yeah.
You choose rocuronium if there are no contraindications, and speed is the overriding concern. You choose rocuronium with Sugammadex if any absolute contraindication to SE exists, or if you anticipate a difficult airway, because the ability to rapidly reverse is a stronger safety net than waiting 10 minutes for STR to wear off.
Let's prepare for the rapid-fire Vivas. These questions test not just knowledge, but the ability to deliver a nuanced, clinically justified answer under pressure. What are the faculty's favorite questions on EFST?
They love questions that link basic science to clinical consequences, like how does ESH increase ICP and what's your plan to prevent it? Your answer has to mention the fasciculation mechanism and affirm that preventing hypoxia is the main goal, not avoiding ESH.
Another one.
What is the dose of ESH in a child and why is it higher? You must say 2 to 3 milligrams per kilogram, explain the larger volume of distribution, and mention mandatory atropine pretreatment.
What about a prolonged block?
A patient's block lasts 45 minutes. What's your immediate management and why must you avoid neostigmine? The answer is ventilate and sedate. You avoid neostigmine because it inhibits Bushi and could potentiate a lingering phase eye block. They also love asking about the 1.5 milligram per kilogram RSI dose versus the 1.0 dose.
And the answer there is that 1.5 is a deliberate overdose for speed.
Exactly, to guarantee immediate, complete receptor saturation.
What are the common student mistakes that instantly signal a superficial understanding to an examiner?
The mistakes often involve confusing the pathophysiology. For example, saying phase I block has fade, or confusing the mechanism of fade in phase 2 with the competitive block of NDMRs.
What else?
Contraindication rigidity. Listing relative risks like a penetrating eye injury as absolute contraindications. This shows a failure to prioritize the overall safety goals of securing the airway. And ignoring the chemistry, not mentioning the fasciculations, as the definitive sign of depolarization.
So how does a student provide that definitive, safe, examiner-approved answer when faced with a conflicting risk, like S and neurotrauma?
The nuanced answer always prioritizes the greater threat. You'd say something like, well, S does transiently increase ICP. The primary goal is rapid intubation to prevent hypoxia and hyperkalemia, which cause sustained and much more damaging rises in pressure. I would use SJA possibly after pretreatment unless an absolute contraindication like a burn exists. That shows judgment and balance.
When structuring a comprehensive 20-mark long answer, presentation is key. What visual aids and structural strategies are faculty looking for?
Diagrams provide immediate high-value information. You should be able to draw two things from memory. First, the chemical structures of HU and TESH, clearly showing age as the two HE molecules linked.
In the second diagram,
A schematic of the neuromuscular monitoring response, the TOF pattern for phase I4 equal twitches versus the TOF pattern for phase 2 with clear fade, looking like an NDMR.
and structurally, how should the candidate organize that long answer for a logical flow?
It has to follow a clear pharmacological pathway with distinct numbered headings, just like we've covered today. Start with classification and chemistry, then mechanism of action with subheadings for phase 1 and 2, then pharmacology and kinetics, systemic effects, clinical uses, adverse effects, and contraindications, with a special focus on hyperkalemia, and then a section on pseudocholinesterase deficiency and a comparison with rocuronium. That structure guarantees you've covered all the bases.
We've thoroughly dissected succinylcholine. Let's distill this down into the most critical, high-yield bullet points for final revision, the facts you need instantly.
Okay, here are the crucial takeaways. 1, SEF is the sole depolarizing NMDA, an SAE dimer. 2, it causes a phase I block, depolarization, fasciculations, and no TOF fade. 3, anticholinesterasers like neostigmine potentiate a phase I block.
Good one.
4, the block is terminated by diffusion away from the NMJ, then hydrolysis by plasma Bushi. 5, duration is ultra short, 5 to 10 minutes. 6, a phase 2 block is diagnosed by 2F fade.
What about the risks?
7, the normal potassium rise is 0.5 to 1.0 meter-tube per liter. 8, life-threatening hyperkalemia happens because of upregulation of fetal AT receptors in denervated states like burns and trauma. 9, MPH is a severe complication and a family history is an absolute contraindication.
And the last few.
10, the DBK number assesses the quality of Bucci. 11, RSI at 1.5 milligram per kilogram is the main indication. And 12, rocuronium with Sugamedex is the preferred alternative when SES is contraindicated.
That brings all the essential facts together. To conclude, what is the model conclusion paragraph that encapsulates the clinical rigor required for a top MD anesthesiology exam answer?
The conclusion must link the drug's utility to its necessary caution. Something like, succinylcholine remains an indispensable agent, unparalleled in its speed of onset, securing its position for emergent airway management. However, its use is governed by strict life-saving principles. The mandatory risk assessment, especially for conditions predisposing to catastrophic hyperkalemia and MH, is the essential safeguard. Mastering the complex pathophysiology of SUM, particularly the distinction between phase 1 and phase 2 and the kinetics governed by plasma Buche, is not just academic knowledge, but a fundamental requirement for patient safety and clinical excellence in anesthesia.
That is a comprehensive and expertly detailed deep dive. If you take anything away from today, remember this. SU's short duration is a powerful safety feature in a tough airway scenario, but that hyperkalemia risk in the wrong patient is a critical hazard. Understanding that nuance is the essence of judgment in emergency anesthesia.
Exactly.
Yeah.
Choose wisely, monitor relentlessly.
You now have the in-depth knowledge necessary to master this cornerstone of anesthetic practice and ace your exams. Until the next deep dive, stay curious and study smart.